Colleagues, my name is Mynzhylky Berdikhojayev. My assistant is Sheikh Mohammed Khan, and we are from Almaty, Kazakhstan, Presidential National Hospital. Today we have several patients, and patient number one, young gentleman, 68 years old. He presented with a vertebrobasilar stroke, and also he had a MCA territory stroke on right side, and now he has a left side slight weakness. And let's see together what we found on CT angiography. It was severe stenosis of the basilar artery. On the right side we can see the stenosis of V1 segment of vertebral artery. Cervical carotid stenosis, not so much, not significant, it's less than 20%. Patient on best medical therapy, and now we can see the MCA stenosis on the left MCA territory. I think there is no delay, but we can confirm on vertebrobasilar injection. Okay, I will accept the calibration now. Just a second. It's look like nearly more than 50% stenosis, but the weakness on the right side, huh? Left side weakness. That's why it's asymptomatic severe stenosis of the MCA territory. Let's see on oblique view. Usually it's very informative. And, there is a petrous segment stenosis, but cervical ICA stenosis we will do a little bit later. Yes, it's look like more than 70%. Okay, let's see. This is a stenotic segment, 1.1 millimeter. My best friend Khairul Azmi presented similar case, but patient was under best medical treatment, and patient had a hemorrhagic transformation of the ischemic stroke, and now he's in real trouble. Patient and my best friend Khairul now in real trouble. The hemorrhagic transformation is correcting everything, and also is correcting the medical management. And physician all the time under big pressure when the patient is deteriorating with such kind of significant stenosis. Yes, in this case the basilar artery is nearly 3.6 millimeter. Stenotic segment is 1.2 millimeter. Proximal vertebral artery nearly 3.6 millimeter, and it's quite long segment. We are planning to place credo stent in this vertebral artery. In this vertebral artery vertebrobasilar. That's the only problem. Our guiding is 8 French, and we need to go all the way up. If it's something like benchmark, maybe it's better. Okay. Shaykh Ahmed made a okay, you can see severe stenosis of vertebral artery and proximal basilar. Yes, our population is quite heterogenic and usually with multiple severe stenosis. Okay, this same, and I think it's a remnant of vertebral artery from the contralateral side. In some cases, some of the colleagues are doing embolization for the remnant of the vertebral artery. Yes, I have seen some cases, and yes, misinterpretation of the remaining part of the artery, and 5.3 millimeter. It's nearly 3.2 millimeter. I think we can observe, but this MCA I think we can leave for the next session. Today we have only one credo 5 millimeter, and the second credo is 4 millimeter. Code on it. Okay. Maybe we can place 2-3 stents. It's no problem. There is a specificity of the coding. Okay, let's angioplasty with the okay, we have guiding 8 French coronary. 8 French coronary, and maybe in this case we can use distal access catheter, but let's see what we can do. On the right side, I think there is nothing on the right side, huh? Shaykh Ahmed? On the right side everything is clear, yeah? It looks like everything is clear. Yes, we have Sigard stent 1030, 940. Maybe for carotid we will use Sigard. Item. Time to time we are speaking in Kazakh language. I hope it's not a problem. For basilar also possible to place coronary stents, and okay, let's see. Maksudovich, 1 second. Okay, I will check the angiography from the right side. Yes, on the right side it's emboliogenic plaque, and this plaque was symptomatic, eh? The right side. And now we are planning to deal with the left side, huh? Okay, maybe we will start with the right ICA territory first. This atherosclerotic plaque, it looks like quite emboliogenic, and yes, I think it's possible just place a Sigard stent in this place, and we can forget about this stenosis. .6 millimeter, but Okay, Sigar Tashpseso. We will start from right side. Shaykhmet. Yes, it's a symptomatic stenosis on the right side. Even the percentage is not so much, but I think it was arterial emboli. That's why it's better to place a stent. It's a plaque with ulcer. That's why I think it's better to stent this stenosis with a double mesh stent from Inspire MD. 1030, I think will be okay. Гепарин стисасныш? Так, на жерге бір байканы жетіп қалыр. And also. Okay, I think the one like connector will be enough. Система бітіп отыр. Екіншісін қосып бересіңші бізге? Ана жерде екіншісін. И ананы сосын ауыстыра саласың ғой? Жарайды? Okay, we prepared neurospeed. But neurospeed for basilar. Системаны бересің. Сделаем блю. Гепарин десмін. Бір кубик. Heparin 5000 units, Besman единица. Yes, it's very important. And it's a JCI accredited hospital, and before the starting the live streaming, I said hello to my patient and verified the name, date of birth, and last name, diagnosis. Yes. And also the diagnosis in this procedure is also verified by angiography. Yeah? We are treating based on angiography, that's why it's not a problem. To clarify the situation about the JCI accreditation, and we are doing timeout, and it's very important. Huh? Before the general anesthesia, the anesthesiologist is doing timeout, and also at every changing the assistant also doing timeout. But in angio systems everything is present, that's why there is no big questions what to do and what not to do. No, Angelo. Okay, we'll just place a credo stent in right carotid. And maybe after placement of the carotid stent, we will think about changing the ostomy. Енді остырасың ба? Басқасына остырасың. И он микрокатетер жалайсың. Yes, and everybody is talking about patient safety, but in Kazakhstan the problem is we have no 1 liter saline, and that's why we need to use half liter saline, and it's quite risky. And now let's do angiography, because the wire is inside the thyroid artery. Yes, it's okay. This looks like I see. It should be something here. It's an atherosclerotic plaque. Okay, let's change for the link view. Link conference view. And if you unlock it well. Okay. Okay, no problem. Smart mask? Okay. The problem with the cigar is the visibility, and it's a nice stand in time when we don't need a protection device, and then it's possible to use. Possible to use cigar, and I pushed a little bit my stand to correct the position. So now it's okay. Okay. I hope we covered the stenotic segment. Yes, the visibility, and there is no markers like in protege stand, and in many other stands we have no markers, but the metal is not so contrast. That's why it might be a little bit problem. And now we isolated the ulcerated plaque, and we covered the stenotic segment with stent. And stent has two meshes. One is metal mesh, nitinol, and the second is metallic. Okay. Yes. Second is plastic one, and plastic one is As today I have a microsurgical assistant. Sheikh Ahmed is microsurgeon. That's why in some points it's better to repeat what I want from side of Sheikh Ahmed. That's another challenge for the operating surgeon. I'm so sorry, but you didn't change the flushing system. Я ж попросил поменять физраствор.
Физраствор ауыстырıyor mu? Анам, қолданып тұрған жоқ па?
Жоқ, бүйтесің, соны алып соған саласың.
Иә, алды. Жоқ, маған просто жақсы істеген еді. Иначе новый физраствор саласың.
Yes, it's very important to have a dedicated assistant. But Sheikh Ahmed falls in microsurgery, and yes, we couldn't say it's not bad, but it's not also good. Microsurgery is about the cutting the skin and cutting the bone. Sheikh Ahmed. Is it microsurgery? Yes, okay. For the stenotic cases, for the basilar stenosis, Sheikh Ahmed will ask for bypass. I'm just joking, yes. That kind of bypass in Kazakhstan, as I know, the only person who already made that kind of bypass is Serik Dushanbe for the vertebral basilar system, and I think in critical stenosis, the main part, yes, the challenge is microsurgery, but also the challenge number two is anesthesiology support. Yes, it's high quality anesthesiology you need to make a surgery possible in a severe stenosis, and that's why in my opinion not in many places it's possible to do adequate bypass for the patient with a severe stenosis. Yes, I think in Barrow Institute with the dedicated neuro team with the hypothermia, it's easy to open everything, to stop the heart, and also Adan is doing cardiac pacing for many intracranial pathologies. But in this hospital it's impossible, it's nearly impossible. That's why we changed our tactic and nowadays we are doing more and more local anesthesia cases. Yes, in our practice we switched for the local anesthesia in nearly 70% of the cases. In ICA aneurysm, ICA stenosis, all ICAT cases, intracranial stenosis cases, we're doing it under anesthesia locale. Okay, just a second. Let's do it like this. Yes, the local anesthesia is a good option, and we need to say thank you to Sadnan Siddiqui. We learned how to use lidocaine intraarterial. Okay, just a second. We need to change our flushing system. It's a problem, huh? Before it was 1 liter saline, but the cost of 1 liter saline is with small difference, and China is killing all medication business in Kazakhstan, and all these salines is coming from the China, and all of them in plastic bottle. It's not a bag. That's why I should say it like this. Not that China is the cause of this. Sheikh Ahmed did somebody is already inflated. Sheikh Ahmed. I said microsurgical assistant, yes. Yes, it's possible to switch from the flashing system to the balloon. Так, вперед. Анжа процент?
50.
Вперед. Вперед. Так, назад хорошенько. Yes, it's a small details, and as my friend Andrei Petrov made a conference on this thematic, he said devil hidden in details. Huh? It's a small details, but there is a devil at the back part. Okay, I will ask to inflate it.
Inflate?
Inflate. Okay. Yes, it's an aerospeed balloon, that's why we can inflate it. Okay, there is a 14. And then I will put it like this. Okay, now deflate completely. Yes, it's narrow speed, that's why we can do it like this. Huh? It's a very elegant technology, and I think it's a human factor. There is no problem. And there is a lot of details. We are short from the instrument this year because of the tenders, because of the agreement between hospital and companies, and etc. etc. That's why we should adapt for this situation, and that's why I decided to leave the governmental system, and now I will think about the private hospital somewhere in Kazakhstan, and to avoid all these mistakes, and to have a possibility to order the correct and the best material, and to provide the best medical services in the region. Okay. Maybe next month I will be self-employed. In Kazakhstan we say self-employed. Самозанятый, да? Self-employed, self-motivated person. And in Dushanbe I have seen the cat lab. It was a small present from the Japanese colleagues, and maybe we'll try to find some cat labs useless, and we can bring it to Kazakhstan. Let's see. Okay, it's a credo stand, that's why I don't need to go with the guiding catheter distally. And now smart mask. That's okay. Yes, I'm visiting Almaty less and less nowadays. That's why Shaykh Ahmed is more dedicated for microsurgery. Онтырт. Медленно онтырт берсін. Шашағы. Аға, қозғалмай жатуға тұрсыңыз, жарайды ма?
Қозғалмай жатыңыз. Қозғалмаңыз. 14.
Все назад. Okay, we'll do step angioplasty. Онтырт. And also possible in the vertebro-basilar system, there is no problem with the placing the credo and then doing the post dilatation. It's easy comparing with the carotid system and the MC territory. It's not all the time possible to do angioplasty post dilatation. Yes, it's a 2.5 by 8 balloon, and when we're doing inflation till 14, 1/3 is a 14. We are inflating till 3 millimeter, 1/3. And there is important point, the proximal basilar. It's possible to place coronary stent, and usually proximal centimeter of the basilar is less perforating arteries. Okay, we made the pre-dilatation. Yes, the balloon was properly prepared. The problem is, okay, now I think we opened the artery. It's looked like a little bit dissection, but it's a goal of the angioplasty. Yes, we are doing dissection during the angioplasty. and then we need to place a stent for this dissected point. Okay. 520. Stent 520. Please.
Stent.
Credo 520. Yes, and the same with the medical support, with the medical drugs support, and when we discharge the patient and saying, okay, you should take a Brilinta, ticagrelor for 6 months, and after discharging, patient is going back home and saying, okay, there is no ticagrelor available, and the local outpatient hospital is suggesting to take a clopidogrel and to change from ticagrelor to clopidogrel. I think in many places the same problem, but the both drugs are different, and it's a systematic problem. Huh? It's not a problem of the physician, it's not a problem of the patient, and the better point, we are sharing our telephone number with our patients. That's why it's very easy to communicate with them. Okay, just a second, I will take out the road map. Everything is moved. Now I will place my credo. I think this part is okay. Now we'll do angiography. Yes, it's a problem of medical service. When you say one recommendation and the system is saying, oh, we have no this medication, patient should take available one. It's a problem, huh? Okay, but it's good. It's free, and patient shouldn't pay anything. And I'm just complaining. I want to work in ideal condition, but it's nearly impossible. It's nearly impossible. Nowadays, I understand it's nearly impossible. Even in the United States, I think it's not possible. Maybe in Spain, Alberto said everything is available. There is no problem with the medical support, and yes. But then there is other problems, huh? Okay, now my delivery wire inside the stent is moving without any problem, and when I see this sign, and I can reinsert my narrow speed balloon inside the credo, it's a good sign. If it's not detached, sometimes stent is not detaching, and then it's possible to move the stent, but in this situation it's okay. Okay, now I will ask Shai Ahmed to give 14 atmospheres. 14. Just also. Yes, on AP and lateral you can see there is a good lumen, and now we need to stop throttle. Stop throttle. Okay, and usually it's not correct 8 millimeter. I wanna show you what I'm thinking of, what I'm talking about. Now we have, okay, let's look for this. The balloon is 8 millimeter. It's correct. From one marker to the another marker is 8 millimeter, and but it's not actually 8 millimeter. It starts here and ends here. It's nearly 14 millimeter, and the actual size is nearly 10 millimeter, and one marker to another marker is 6.3. Even this is 8 millimeter, this is nearly 12 millimeter, and this is nearly 17 millimeter. And when you are doing angioplasty, you should notice these small details. It's a quite small details, but it's very important when you change from ICA from ICA to MCA. It's very important. ICA diameter is bigger than MCA, and the MCA M1 segment is bigger than M2 segment. And when you inflating the balloon, you should keep in mind this extra 4 millimeter forward and 4 millimeter backward to the marker. It's very important. It's very critical. Okay. Okay, let's take out the roadmap, and now we can push a little bit the balloon, and I will ask Shaykhnet to give another 114, and then we will do 14 in the proximal part of the stent. Yes, it's a 14. Okay. And the nerve speed 14 is 306, nearly 3 millimeter, but the balloon is 2.5 millimeter. And my teacher and friend René Chapeau is doing inflation with this 5cc syringe, and with 5cc, if I will compress the 5cc syringe, it's nearly 16 atmospheres. If my assistant Shaykhnet will compress, it will be 24 atmospheres. Okay, Nazat. And if some young lady will compress the 5cc syringe, it will be nearly 6 atmospheres. It's very important, huh? Okay, еще раз. One more time, we will inflate the proximal part of the basilar, and we need to inflate the and one of the marker of the credo. On lateral, all markers are correct. Okay. Okay, awesome. And this medical system is not supporting the physicians, and it's possible to go to the court, and if some complication happen, the only guilty person will be the physician. And now we are using the syringes. It's a correct syringe, and sometimes we use incorrect syringe, and it's also the big problem. Okay. Now the diameter of the basilar is enlarged. Let's measure. It was 1.2 at the beginning, and now it's not the 2.73 millimeter. It's nearly, I hope it's even nearly 2.2, maybe 2.4 millimeters. The distal basilar was 3.6. Now it's 3.9, but there is a mismeasurements, might be. It's a 2.5 millimeter. It's good. And this point is 2.4 millimeters. Мына пациенттің слайдтарын маған презентация жасап бересіз. Ертең доклад оқыған кезде керек болды. Yes, 2.5, and there is one more stenotic points here. 2.5, yes. It was 1.2 and now it's a 2.5. We corrected the artery diameter till It's nearly 40% of stenosis now remaining. And the stent is 5 millimeter. It will keep enlarging during the time, and the body temperature is warming the nitinol, and trying to go to the initial size 5 millimeter. Yes, it was presentation from the Hans Henkes team from Stuttgart. Our colleague is presented solitary B experience in critical basilar stenosis, and it was very nice follow-up of those patients. They just placed the solitary B detached without angioplasty, and during the follow-up at 6, at 9 months, at 1 year, the artery became larger. Yes, the stent is working, and the body is working, and the stent is enlarging, and it's very nice illustration. And that's why in intracranial stenosis, it was before this presentation, I think we did from our subcortical part. We start to place 5 millimeter credo. It's trying to enlarge the artery, and we see it immediately in MCA territory, but in basilar it's not all the time, but during the time the credo is also working. Okay, now we will do acquisition without zooming. Аға қозғалмай жатыңыз. Аға қозғалмаңыз, қазір бітіреміз. Қозғалмаңыз. Қауыз құрғап кетті, қазір. Шыдай тұрыңызшы, бітіреміз қазір. Сәл ғана қалды. Палатаға барасыз, жақсылап су ішесіз ғой. Қозғалмаңыз, қозғалмаңыз. Yes, the basilar looks much more better. Yes, and at the point of these stenting cases, we are keeping in mind all these patients after stroke, and they have some kind of encephalopathy, and it's very important to correct the medicament management, and we need to keep in mind patient may forget to take medication. Okay, let's do expert CT. Аға қорықпай жата беріңіз, 2 стенд қойдық. Бәрі ойдағыдай, Құдай қаласа 1,5 айдан кейін тағы келесіз. Сол жақтағы тамырда 2 жерде тарылған жер қалды, соған тағы да стенд қою керек. Оң жақта инсульт болған жағына стенд қойдық, сосын жерге жақта үлкен тамыр бітелейін деп тұр екен, соны аштық. Жақсы ма? Қозғалмай жата отырыңыз, қазір 5 минутта бітіреміз. Ем болсын аға. Ау, влажный салфетка аузына саласыш, бір тамшы су. Ана бір салфетканы алды, аузына су тамшы. Таза физрастор. Okay, let's wait for the control CT. Очередная блестящая операция. Dear colleagues, the city is ready. I don't see big territory of stroke, but this is an expert city and it shouldn't be okay. Let's do it in NPR. And, I hope now it's better. Yes, there is no complication. It's a 1 point. You place the stent in right carotid territory, and there is a stent in basilar. You can see the stent, and subarachnoid space is clear, and the brainstem is clear. Okay, now we can finish this case, and next case is Spitzer-Martin 5 brain AVM after several stages. Young lady with brain AVM, and it will be under general anesthesia. And see you in next 30 minutes. Thank you for watching. See you.